Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome our very renowned doctor, Dr. K. Suresh. Sir is MD, DIH, DF, FIAP, FIPHA, FISCD, family physician, public health consultant, Bangalore, and visiting professor of practice at KSRDRU, Karnataka. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is syncope in elderly orthostatic hypotension or hidden uh, arrhythmia. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Thank you. Good evening, friends. Today we are talking of a common problem among the elderly for many reasons. That's syncope. Most often we'll be stressing on the two components of these multiple causes. One is what is commonest is orthostatic hypotension. The other related to structural problem of the heart, basically arrhythmia, and another structural problem. My presentation takes you through basic introduction, a case reports which I have seen in the recent past, and types of common syncopes, that is vasovagal, orthostatic, and other types of syncopes, finally summarizing the day's session. You all know syncope or fainting is basically characterized by a sudden temporary loss of consciousness and postural tone. This happens due to decreased cerebral blood flow and it is accompanied with spontaneous recovery. It affects many people. It could be for some trivial causes or could be diseases of risk to death. In the larger context, we classify syncopes to three causes: neuronal or reflex mechanisms. Second is orthostatic hypotension. And third is cardiac causes. Reflex syncope, when we say, it is a sudden drop in the blood pressure and also heart rate due to a trigger. The trigger could be as simple as fear, seeing blood, or any sudden jolt. Orthostatic hypotension is a drop of blood in the blood pressure on standing. Please note it is on standing. It is often due to impaired blood pressure regulation. Both of them can lead to temporary loss of consciousness. Cardiac syncope, on the other hand, refers to episodes where the cause of the cerebral hypoperfusion is directly related to a cardiac disorder. Arrhythmia is the commonest among the cardiac conditions, where both bradycardia and tachycardia, or what we call as the brady and tachyarrhythmias, can cause a sudden decrease in cardiac output and produce syncope. This slide summarizes the common symptoms on one side and the etiologies. The commonest thing is what we call as a blackout. Person suddenly feels he can't see anything. Feeling a light headache or sometimes fall for no reasons. Feeling dizzy. Feeling drowsy or groggy. Fainting, especially after eating or exercising. feeling unsteady or weak when standing, changes in vision such as seeing spots, tunnel vision, and sometimes headache. As already discussed, the second portion of this slide summarizes the etiologies. The most common being reflex are the neuron mediated, in which they cause about 60% of the total episodes. In this, we get three categories: vasovagal, situational, and carotid sinus problems, followed by orthostatic hypotension, which basically occurs to volume depletion, sometimes some drug induced or autonomic failure. These contribute about 15% of the syncopes. 10% of cardiac causes, usually arrhythmias, either it is brady or tachy arrhythmias. Structural problems include to the tune of 5%, basically valvular, obstructive, pump failure, and vascular causes. So this slide just summarizes what I have talked already. To understand the basics of pathophysiology, human physiology, when a person stands, the gravity causes the blood to pool in our lower limbs. This might potentially lead to a drop in blood pressure and reduced blood flow to the brain. To counteract this, the body activates what we call the sympathetic nervous system that constricts the blood vessels and increases the heart rate to maintain blood pressure. Secondly, muscles pump and the non-uniform distensibility of the blood vessels help to return the blood to the heart. The second portion of this slide just describes the proportion of each one of these four categories, which we already discussed. Now, in terms of clinical conditions, what you can see in your outpatient, most common is orthostatic hypotension, followed by carotid sinus syndrome, vasovagal syncope, structural cardiac abnormalities, cardiac arrhythmias, and conduction abnormalities. Now I'll walk you through about half a dozen cases which give an indication of varieties of the syncopes. The first case is about vasovagal syncope. Here, a 62-year-old woman, living independently, presented after a brief losing consciousness while straining on the toilet. She comes to me, said, "Sir, I was sitting on the toilet, strained myself, and felt syncope." The patient felt well immediately after the event. No associated trauma, confusion occurred. The patient had experienced similar episodes since last 6 months. An ECG was done, but it was normal. Her past history indicates of stroke affecting the posterior circulation, and she was on secondary prevention treatment with aspirin, etc. My initial assessment showed normal vital signs, no signs of volume depletion, and the normal results on cardiovascular and neurological examinations. Since the presentation was consistent with an uncomplicated episode of syncope, without any risk factors or any neurological defects, a diagnosis of vasovagal syncope was made. The other common cause among the elderly particularly are there are multiple factors play. Just 2 weeks ago, one of our friend in the apartment complex, age 86 year, frail, hypertensive, known cardiovascular patient, and also senile dementia, was standing near our facility manager's office and suddenly fell down, hitting his head onto the wall and was hurt on his forehead. I was called on a telephone. I ran within 2 minutes down the stairs. Here, the person was on a physical stress, according to my judgment, which was the trigger, because he had had a routine walk of about 2 miles, and after that was standing for quite time, then sat for a while, and suddenly got up to go home as his spouse called him. The sequence of events were trigger of walking and standing for 15 minutes, sitting suddenly and getting up to go move further. Here, the nervous system overreacted, causing blood vessels to dilate, and heart rate was down. The combination of vasodilatation and bradycardia led to reduced blood flow to the brain, causing lack of oxygen and syncope. However, he recovered within 5 minutes of hitting the ground, as the blood flow to the brain is restored and consciousness returned. On my examination, nearly after 10 minutes, the blood pressure was 116 by 64 in supine position and 96 by 52 in standing position. He was also on antihypertensive drugs, amlodipine. So therefore here, both postural hypertension, drugs, and many other causes cause this syncope. We call this multi-factor syncope. There is another case of a lady who was consumed amlodipine tablets. The incidents that this lady, about 40-year-old, she came to me in an emergency. I was called when she was unresponsive. Her husband or boyfriend told that they had an argument in the morning, after which he left for work. When he arrived at home, he found her lying in the bedroom, foaming at mouth and unresponsive. Nobody knows how long she was in that position. We shifted this lady to the emergency of the specialty hospital. The heart rate was 76, BP was 76 by 42. She was given naloxone and respiratory rate was improved to 16 beats per month from about 6. She did not demonstrate a change in the mental status. Subsequently, she was intubated, and the rest of the patient history was initially limited to secondary to her unresponsive state. After further investigation, a bottle of amlodipine pill was found near her bed, though she was not on the medication, but her husband was using them. So here, both amlodipine and tricyclic antidepressants are known, if taken in overdose, are known to cause syncope. Here, a electrocardiogram ECG reveals a QRS duration of more than 100 minutes with associated R wave in a VR. So amlodipine is known to cause, for example, even my personally I use amlodipine tablets. Sometimes if I sit down and get up, I do feel a little of what we call as male with a history of exertional dyspnea, giddiness, and recent syncopal episode. Again, this case was referred based on a scanning. Is severe calcified aortic stenosis was recognized and the wall structure and the blood flow. The patient had experienced dyspnea for last 4 years, but the syncope was there only for last 6 months. Similarly, another patient also with multiple syncopal episodes complaining of visual loss, incontinence associated with syncope. All these episodes were diagnosed usual echocardiography with a potential in severe aortic stenosis. Arrhythmia led syncope. A 20-year-old male with known comorbidities, irregular in medication, came to us with a history of nausea, chest discomfort, followed by loss of consciousness for about 3 minutes. That is on exertion after doing exercise. There was no confusion. History of similar episodes twice in the past, in about 5 months ago and 1 year ago, was noted. There was no history of tongue bite, any tonic-clonic movements, bowel and bladder disturbances are also not there. There was no history of sudden cardiac death in the family or any heart disease. On examination, patient was conscious, oriented. His heart rate was 58, BP was 130 by 80, respiratory rate was 18, and S1 and S2 positive on ECG. There are no murmurs. There are no neurological defects. The case was referred to tertiary care facility. ECG showed sinus rhythm with a rate of 58 per minute. T wave inversion in V1 to V5, poor R wave were also seen. Echocardiogram revealed dilated right ventricle, moderate right ventricular dysfunction, normal left ventricular function, and RVOT of 43 millimeters of mercury and PASP of 13 millimeter Hg. Holter showed ventricular ectopic, which we call as bigeminy, couplets, quadrigeminy also, ventricular tachycardia. The case was diagnosed as arrhythmiogenic right ventricular cardiomyopathy, treated with sotalol and automated implantable cardioverter defibrillator. After 1 day of the ICD, the patient delivered, shock delivered by the device, VT was continued. So he was put on amiodarone and lignocaine infusion, patient monitored for 4 days and discharged with tablet sotalol. Multi-pharmacy, that is, people who are elderly people, for example, I take at least about half a dozen of different drugs for various conditions. Sometimes interaction between these multiple drugs may also lead to syncope. At 78-year-old woman with history of coronary heart disease, congestive heart failure, atrial fibrillation, and Parkinson's disease, came to us with dizziness and inability to stand. Orthostatic blood pressure measurement revealed a significant drop in blood pressure upon standing, indicating orthostatic hypotension. She was diagnosed with neurogenic orthostatic hypotension and prescribed droxidopa, which improved her symptoms and ability to stand. How does the polypharmacy affect for orthostatic hypertension? This occurs among older adults basically because they are susceptible to orthostatic hypertension due to age-related changes in the blood pressure regulation and drug metabolism. Polypharmacy increases the likelihood of adverse drug interactions and side effects. Specific drugs which may cause include antihypertensive, antidepressants, alpha blockers. Age-related decrease in kidney and liver function also affect the body processing of medications, leading to increased drug concentration and side effects. This orthostatic blood pressure reflex pathway also gets affected due to these multiple drugs. The other causes among elderly people is frailty and cognitive impairment will complicate the presentation of the symptoms. Some trivial things like constipation can also cause, as we saw in his first case here. Here is a lady of 55 who presented after syncopal episode during defecation. On arrival, she was good. There has no remnants of the event. She complained of a significant constipation for the last 2 years and was using regular laxatives. There was no other significant history to warn about syncope. However, her BP was 100/60 with regular pulse of 72 per minute. Oxygen saturation was also normal at 96. ECG showed normal things. There was no significant postural change in her BP. But a structural defect, what happened was this lady, while she was with us, she got a symptom of defecation. She said, I want to use the toilet. She was given a bedpan, and during this process, she went into shock again. On an examination, a huge mass was prolapsed through her vagina, which was basically a fibroid on her cervix. A pelvic ultrasound was done, which indicated multiple intramural fibroid with normal adnexa and a huge cervical fibroid. Only a surgical intervention of vaginal polypotomy helped her to improve on the constipation and syncopal attacks. So with this half a dozen, we know there could be as trivial reason as constipation or as bad as arrhythmias or structural heart problems. Now, looking into the public health concept of here, in India, we know about 3% of males and 5% of females are known to have syncope at any given point in their lifetime. The chances of getting syncope increases as the age advances to as high as 6% in people aged more than 75 years. Rough estimation indicates that every 1 in 2 people will suffer at least one episode in their lifetime. The nature of first syncope is bimodal. That means either the youth, young people between the age of 10 to 30 years for the first time get it, or second peak comes among people over 65 years. India witnesses about 5 lakh cases of syncope every year. When they come to our knowledge, it does not mean they are the absolute number. 1/3 of them are recurrent, and 70,000 of them are, we do not know what the reason is. As we already indicated, 10% of syncope, with all your investigation, you may not be able to pin down the cause. As we already discussed, in India, vasovagal syncope is the most common, followed by orthostatic hypotension, particularly in aged people. Cardiac syncope is the third common. Syncope in childhood is also common, but it is not the discussion of today's subject. So neurally or reflex related is what we have already discussed. Now talk of vasovagal. Basic definition here is development of hypertension and bradycardia with typical clinical manifestation of pallor, sweating, and weakness, and complete loss of consciousness for not more than 20 seconds. Please note, if somebody is unconscious for more than half a minute, then it is not syncope. It is very frequent and benign. Most people may not need any treatment. But if these episodes repeat, what are called as repeated episodes, then they may need significant investigation. They also pose both health and social challenge. VVS, or transient loss of consciousness, is also a commonly known people in dental practice, particularly when they do dental extraction or maxillofacial surgeries. We do not know what is the afferent part of the vasovagal reflex, but we know what happens. The afferent part is a reflex is clear as there is hypotension and bradycardia due to inhibition of sympathetic system or specific activation of the parasympathetic system. Reflex usually occurs during regional anesthesia, bleeding, or compression of the inferior vena cava in the supine position. Vasovagal syncope is usually of two types. One is caused by emotional or orthostatic stress and can be diagnosed just by taking history. Most common in the age of onset of this condition is around 13 years. Non-classical vasovagal syndrome, it consists of episodes without obvious precipitating events, diagnosed by clinical criteria, exclusion of other causes, and positive response to the tilt test. Tilt test is basically changes the position of the patient when you record the blood pressure. So when there is change, when you are vertical, it indicates orthostatic. Orthostatic, as already indicated, is a change of position from sitting or sleeping to standing, causing low blood pressure. The general criteria we use is a drop of 20 millimeter of mercury in systolic pressure and 10 millimeter of mercury in diastolic blood pressure from sleeping, sitting to standing position. If that occurs, we diagnose it as orthostatic. Pre-syncope, as I told you, I do suffer such one, is a prodrome of syncope in the absence of transient loss of consciousness in a person using countermeasures like sitting or lying down to avoid. So most of us who are on drugs and hypertensive, if you have an opportunity of sitting down and getting up, particularly happen when you go for purchasing vegetables in sandy days, when you sit down and pick up and get up. If you get up in a hurry, you are likely to lose postural tone and even loss of consciousness. So when you take support of something or get up in such a way that your position does not change straight away, slowly you change, then you can manage. This slide compares the reflex and orthostatic syncope. Basically, the mechanism, as I told you, reflex syncope has various stimuli, whereas orthostatic syncope occurs only when you stand up from a seat, sneezing, coughing, defecation, etc. Orthostatic causes due to autonomic nervous system dysfunction, hypovolemia, or certain medications. Are lightheadedness, nausea, sweating, visual disturbance. In orthostatic, you can avoid it by doing taking some support. Trigger usually by specific orthostatic, the trigger is
So sorry to interrupt. Your video is stuck, sir. I will request everyone to stay with us as sir is facing some network issue. He will be joining us shortly. We are trying to reach sir out. As meanwhile, I will request everyone to be with us as sir is facing some issue which we are trying to resolve. Thank you. I will request all the viewers to be with us. Sir will be joining us shortly. Uh, Respected audience, firstly, I would like to apologize because today's speaker, Dr. K. Suresh, couldn't join back as he's facing some emergency for which I have to wind up today early. And thank you for your patience and please stay tuned with us for our next session. Thank you.